Now let's examine dementia in a bit more detail. And we remember that we talked earlier that the DSM-5 will now refer to the category of these disorders as neurocognitive disorders, but dementia will still remain in that category. But we'll see that it'll be listed by a variety of its different etiologies or causes. We want to remember that the prevailing idea behind dementia is decline of one's cognitive and executive functions. So cognition, remember, is the ability to think, and executive functions are those functions where we're integrating all of our thinking capacities to switch tasks, to plan, to recall memories when we need to, for example. And so that's what we start to notice when an individual is going through dementia. There are multiple causes of dementia, and we need to realize that basically if it's something that affects a person's brain, a disease that affects the brain, it's very likely a cause of dementia. So that can include something like Huntington's disease or HIV/AIDS, or of course Alzheimer's disease. And of course many of us are becoming very familiar with Alzheimer's disease because it's the most well-known and most prevalent form of dementia. Alzheimer's disease occurs when there's a buildup of what we call amyloid plaques in the brain tissue. We're still not exactly sure why that occurs, and we don't have a cure for this or other forms of dementia. And dementia is typically a terminal illness. We'll talk a little bit more about that in a moment. The most common symptom of this particular decline is memory loss, and that decline in memory can be slow or rapid depending on the individual's case. If a person has the symptoms of dementia before the age of 65, we'll usually hear them referred to as having an early onset of dementia. And this can happen because of a variety of reasons. But people, for example, with HIV/AIDS may experience it before the age of 65. And also, as we mentioned way back in Module 1, people with Down syndrome are commonly going to experience dementia before the age of 65. The incidence of dementia tends to be rising, and the reason is actually based on some good news. It's because we seem to be surviving some of the things that were more prevalent killers in previous generations, particularly cancer and heart disease. So as we improve our fitness in dealing with those particular diseases, we are likely to live longer and therefore be exposed to dementia as a result. The type of memory that a person loses can differ, and there is what we call anterograde memory, which many people often think about as short-term memory, but it's basically the memory we create so that we can function in day-to-day life. And those same people may actually have that function, but lose their distant memory, or vice versa. The person who has a good anterograde memory but doesn't have good distant memory can be more difficult to see the signs of dementia in than the individual who may retain good distant memory but has difficulty remembering where they put the salt 5 minutes ago. And that's where we start to really be aware of the individual with dementia in most cases. But some of these executive functions we spoke of earlier will also be lost. And again, executive functions happen wherever a person has to integrate thought processes, for example, planning or switching between tasks and avoiding distraction. Some of the things that we might see are what we call dysphagia. Dysphagia is a symptom that might happen in a more advanced dementia patient because what it refers to is them losing the ability to swallow properly. A person may also be aphasic. Aphasia refers to the loss of speech, and before the person completely loses their speech, they would probably be dysphasic, meaning they would lose some of their ability to speak. And agnosia refers to the person having difficulty recognizing familiar objects, people, and experiences in their life. And so you can see how these things can be very invasive in the life of a person with dementia, and how they can gradually create a dependency by the person on others for their care. What becomes very difficult for the individual providing sort of familial care for the person with dementia is that the rate of these particular declines can be very erratic and very sudden. So a person might seem as though they're manageable on one day, and the next day they may have a complete loss of ability to take care of themselves. And then again, that may be fine on the third day in a row. So it can be very challenging. The other thing, of course, is that sometimes when people are going through these disorders, their behavior may be aggressive, erratic, scary, and sometimes even assaultive. And so you hear cases, for example, where lifetime partners, the people who've been married for a long time, and one of them starts to go through Alzheimer's or other forms of dementia, where the person who's sick really makes life difficult for the individual who's the caregiver, because their personality is essentially lost, and this other type of behavior can occur. So as we said, the person may become very agitated and aggressive, and even if the person wasn't like that yesterday or a week ago, it doesn't mean that that isn't a potential down the road. And it can be difficult for people to get the kind of help that they need and support that they need to actually be trained effectively and have coping support when they're providing care to a loved one with dementia. Now a closer examination of delirium, which is also a neurocognitive state. It's a transient state or a fluctuating state. People may go in and out of this delirious condition. It's characterized, as we said earlier, by confusion, disorientation, emotional dysregulation. In other words, the person seems to not be able to control their emotions, or agitation. It can occur in people who are demented, but it's not the only time that delirium occurs. It can also be caused by stress, trauma, fever, medicines or drugs, illicit substances, brain injury, and it's treated normally by addressing the underlying causes. So in other words, the clinician has to assess what's causing it, and that can be a difficult process. It can also be caused by physical or emotional stress, including anoxia, in other words, the withdrawal of sufficient oxygen for the individual. It's estimated to affect 10 to 20% of hospitalized individuals. So if a person is going into shock or they're having difficulty breathing in any type of treatment in a hospital, they are at risk of delirium, which means that they can become a disruptive and challenging patient, and their needs can make it rather difficult to provide care for them where there are other patients around. And this may involve the need for security personnel or for additional staffing to supervise that individual.